Hello once again everyone, welcome to another video, and in this one we will be talking about the different cytochemical stains used in hematologic conditions. The different kinds of cytochemical stains to be discussed in this video would be the Leukocyte Alkaline Phosphatase, Myeloperoxidase and Sudan black B, Periodic Acid Schiff, and the two different kinds of esterases. And at the end of the video, in the summary, we will also give the expected reactions of TDT or terminal deoxynucleotidyl transferase. There are different diagnostic tools used in hematology. Some of these are routine staining and morphology, immunophenotyping, cytogenetics, molecular biology, and cytochemistry. Cytochemistry pertains to the study of the different chemical constituents that are present inside the cells. We do this by using special stains known as cytochemical stains. With these different kinds of special stains, we are able to classify and differentiate the different types of leukemias. Techniques such as cytogenetic analysis and molecular testing are now commonly used in the diagnosis of leukemia. However, older techniques such as the use of cytochemical stains still retain their importance because of their different advantages. Some of these advantages is that the stains are relatively cheap, and they can be performed in laboratories anywhere in the world, including in areas where there is limited resources and in areas where there is limited access to advanced techniques. The different kinds of specimens that can be used in cytochemical staining would be the bone marrow, lymph nodes, spleen, and the peripheral blood. There are two general techniques used in cytochemical staining. We have the enzymatic method and the non-enzymatic method. General differences of these techniques is that in enzymatic technique, we need fresh smears to be prepared to retain the enzyme activity of the cells. Examples of these would be MPO and the esterases. We also have the phosphatases. For the non-enzymatic technique, they can be stable for up to months if they are stored at room temperature, and examples of this would be SBB and PAS. Let's now proceed with the first cytochemical stain, which is the leukocyte alkaline phosphatase, or abbreviated as LAP. Alkaline phosphatase, or ALP, pertains to the enzyme that can remove the phosphate group from a molecule. Alkaline because this is the environment where this enzyme is stable and works at its best. ALP may be found in different kinds of tissues, but the ALP that we are interested in cytochemistry is found in a specific cell, which is the leukocyte, which is now known as the LAP. As the name suggests, LAP is found in leukocytes or white blood cells in varying degrees. It is most evident in the mature form of the white blood cells, such as the neutrophil and the band form, because LAP is found in the secondary granules of the neutrophils. Sometimes there may be some or very small LAP found in B lymphocytes. The purpose or the significance of the LAP in the cell is that it is involved in the digestion of the phagocytized material. Therefore, it is involved in the defense mechanism of the neutrophil. LAP in hematology is very useful in differentiating Leukemoid reaction from chronic myelogenous leukemia. Different conditions can give an increase of leukocyte alkaline phosphatase. Some of these increased values are found during pregnancy, usually during the last trimester. Also in infections where there is neutrophilia or an increase in neutrophils, people with polycythemia vera, people taking corticosteroids, patients with aplastic anemia, multiple myeloma, myelosclerosis, obstructive jaundice, and as mentioned earlier, Leukemoid reaction. Decreased LAP scores may be found in CML or chronic myelogenous leukemia, where there is a presence of the Philadelphia chromosome. They can also be found in patients with PNH, sickle cell anemia, hereditary hypophosphatemia, marked eosinophilia, and sideroblastic anemia. Used to determine the LAP score of a patient is the Kaplow's method. Now, the LAP score is usually performed when there is an increase in the white blood cell count, and we need to differentiate the reactive process or the Leukemoid reaction from the CML. The Kaplow's method is performed by examining blood smears microscopically in a relatively thin area of the smear using the oil immersion objective. And we have to count 100 consecutive neutrophils. Again, we are counting neutrophils. And we also have to grade each of these cells based on their appearance. So again, in the Kaplow's method, since we are counting, we are identifying the quantity, and since we are grading them in their appearance, we are also trying to see their quality based on the precipitated dye which is present. Depending on the solution or the procedure performed, the color of the precipitate may vary. It can be deep blue, reddish brown, or black precipitate. The normal value for the Kaplow's method is 20 to 100. Now, to identify the quality and the quality of the neutrophils, we use a certain scoring system. 0 is given to cells when there is an absence or no precipitate as seen in this cell. 1 plus is given when there is a faint or a slightly diffused precipitate which is present in the cytoplasm of the neutrophil. 2 plus is given when there is a pale or a moderately diffused precipitate. In this image, the pink staining lobes of the neutrophil are still very visible, and the cytoplasm has darker precipitates compared to the 1 plus. 3 plus is given when there is a strong or a heavily diffused precipitate present in the neutrophil. The intense precipitate present in the cytoplasm is seen, and the lobes are still visible. And lastly, 4 plus is given when there is a deep or heavily diffused precipitate. So as you can see, there is a more intense staining of the granules in the 4 plus compared with the 3 plus, and the nucleus are no longer that visible compared to the 3 plus. So now we have to count 100 neutrophils. So let's say this is the number of cells that we have counted in the smear. We have seen 33 cells that look like 0 or no appearance of precipitates, 10 cells that look like this, 15 cells with 2 plus, and 21 cells with a 3 plus description, and lastly 21 cells with this very intense precipitate present. So again, these are 100 cells. The next thing that we have to do is to determine the LAP score. We do this by multiplying the count with the score. So let's say 33 is multiplied to the score of 0, and we have an LAP score of 0. 10 is multiplied to the score of 1, we get 10. 15 is multiplied to 2, equals 30. 21 is multiplied to 3, equals 63. And lastly, 21 is multiplied to 4, and we get 84. The next thing that we have to do after determining the LAP score is to add all of this up, and the total is 187. If we are to compare it with the normal value, 187 is increase, and an increase in an LAP score would determine that this is most likely a Leukemoid reaction and not a CML, because CML has a decreased normal value. So that means there should be less than 20 of the LAP score for us to say that it is CML. The next set of stains to be discussed would be myeloperoxidase, or MPO, and sodium black B, or SBB. In general, both MPO and SBB may be used to differentiate acute myeloid leukemia from acute lymphocytic leukemia. But to differentiate these two, MPO, or myeloperoxidase, is an enzyme, a lysosomal enzyme that is found in the primary granules of granulocytic cells like neutrophils and eosinophils, and sometimes up to a certain extent may even be found in monocytes. SBB, on the other hand, is a dye. It is a fat-soluble dye that is able to stain intracellular lipids like neutral fat, cholesterol, phospholipids, and sterols. Unlike myeloperoxidase that may only be found in primary granules, SBB may be sensitive or may stain the fats that are found in the primary and secondary granules of neutrophils and in the lysosomal granules of monocytes. That is why SBB is considered as a more sensitive dye or a more sensitive method for determining the granulocytic precursors. Since myeloperoxidase is an enzyme, we need to use a stain, a peroxidase stain, to identify the presence of the myeloperoxidase enzyme. One of the disadvantages of the MPO method is that it uses 3,3-diamine benzidine tetrahydrochloride, which is a substrate being used in one of the methods, and this is a potential carcinogen. That's why certain precautions should be observed when handling this reagent. The peroxidase enzyme is also sensitive to light. That's why smears should be stained immediately, and if the smears are more than 2 weeks old, or if they have been exposed to light, these will give a false negative result and should not be reported. One disadvantage of SBB is the time necessary to perform the stain, and this usually takes around 1 to 2 hours. Since both MPO and SBB would be able to identify the presence of granulocytic cells, then acute myeloid leukemia would give a positive result for these two methods. And since monocytes may also give a weakly positive result, therefore acute myelomonocytic leukemia may also be positive. Our rods, which are found in leukemic blasts and promyelocytes, will test strongly positive for MPO. Since MPO and SBB would stain the granules present in the cells, therefore cells with no granules will be negative. So that would be lymphocytes, erythrocytes, and platelets. And in a hematologic condition, that would be acute lymphocytic leukemia. Different methods would give different colored reactions for MPO. It may be red-brown as seen in this picture. So these are the precipitates. So these are your blasts. And it may also be dark brown or black in color as seen in this picture. So these are the positive cells, the one with the brown or black color precipitates. Sodium black B, as the name itself says, black, it gives a brownish black color of precipitate. And our positive cells would be the ones with a dark color of precipitated granules. The next cytochemical stain to be discussed is the periodic acid Schiff. Next is the PAS, or the Periodic Acid Schiff, and I would like to emphasize on the pronunciation. It's periodic and not periodic because this contains iodine. And the PAS is used to stain the mucoproteins, glycoproteins, and the high molecular weight carbohydrates. So in short, it stains the glycogen that is present in the cells and the carbohydrates or the sugar inside the cells. And normally, all blood cells would have glycogen and would therefore be positive for PAS, with the exception of the erythroblast, which is normally PAS negative. Now, the intensity of the stain and the pattern of the stain will vary in each of the different kinds of cell. The pattern may be diffuse, granular, or it may be a mixture of both. As just mentioned, in normal conditions, erythroblast reaction for PAS is normally negative. But in disease conditions, the PAS reaction will be different from the normal state. That is why in erythroleukemia, which is an abnormality in the erythrocytes, also known as the FAB-M6 or the D. Guglielmo's disease, pronunciation is silent G, this would give a positive PAS. Other conditions that give a positive staining of the nucleated red blood cells would be in thalassemia, iron deficiency anemia, and other hemolytic anemias like pernicious anemia, aplastic anemia, and polycythemia. In CLL and lymphosarcoma and in Hodgkin's disease, the lymphocytes contain an increased number of positive granules. To be more specific, the three types of cells that may give a decrease or a negative value for PAS would be the erythrocytes, the monoblasts, and the myeloblasts. To differentiate the different kinds of patterns in each of the different kinds of cells, granulocytes will normally have a diffuse pattern as seen in this picture. It will show this pattern in all of its stages, but with the mature neutrophils giving the strongest reaction. Lymphocytes, on the other hand, is more of a granular pattern as seen in this picture, where granules on the cytoplasm are seen. Myelocytes and monoblasts or myeloblasts would contain fewer positively stained granules. Eosinophils, the granules will not be stained, but the cytoplasm itself will stain positive. Lymphocytes will have a few fine or coarse granules to be positive. Monocyte granules will exhibit a small amount of positive staining. The next set of cytochemical stains would be the specific and nonspecific esterases. The esterases are used to differentiate neutrophilic granulocytic leukemias from monocytic leukemias. That is because white blood cells contain esterases, which are lysosomal enzymes, and there are around 9 isoenzymes of esterases that may be found in leukocytes. Two substrate esters are commonly used. We have the specific and the nonspecific. The specific method is also known as the leukocyte esterase method, which uses the naphthol ASD chloroacetate, also known as the letter stain. And this is able to identify the granulocytic series, therefore the name specific because of the fact that only granulocytes will stain positive, unlike the nonspecific where other cells may possibly be stained as positive as well. For nonspecific, we use two substrates, either the alpha-naphthyl acetate or the alpha-naphthyl butyrate, and both of these substrates would be able to identify monocytes, because both these substrates are present and most abundant in monocytic cells, therefore is also used in the diagnosis of monocytic leukemia. Between the alpha-naphthyl acetate and alpha-naphthyl butyrate, it is the butyrate that is less sensitive but is more specific for monocytes. An increase or a positive esterase stain will be seen in the following. For the specific, which is positive for granulocytes, may also be positive for promyelocyte, myelocyte, and metamyelocyte, although myeloblasts will generally show a positive reaction and our rods will show a positivity as well. The non-specific esterases will show a very strong reaction to monocytes, but macrophages, megakaryocytes, and platelets may also show positivity. For the specific esterases, they would be negative to the monocytic series, and that would include the monoblast, promonocytes, and monocytes, and will also be negative to some of the myeloblasts. For the nonspecific esterase, in the presence of fluoride, so when fluoride is added, the reaction would be inhibited. So therefore, the monocytes, the macrophages, megakaryocytes, and platelets will all give a negative reaction. The chloroacetate esterase activity will show up as blue staining granules in the cells as seen in this picture, while the nonspecific esterase activity would be indicated by the presence of dark red staining granules in the cytoplasm of the cell. A technique where both esterases are used in the smear is known as the combined esterase stain, which is useful in the identification of M4, and M4 is acute myelomonocytic leukemia. Since M4 would have the myeloid cells or the granulocytes, it would stain positive for the specific esterase, which is shown as blue staining granules, and for the monocytic part, which is for the non-specific stain, will stain as red staining granules in the cytoplasm of the cell. So if both of these are present or positive, then that means that the patient may have M4 or acute myelomonocytic leukemia. Let's now give a recap of the different cytochemical stains that have just been discussed. Let's start with MPO and SBB, and as the name suggests, myeloperoxidase is for the identification of myeloid cells. Therefore, all conditions that are myeloid in origin would be positive for both MPO and SBB. M5 is more on monocytic, so may give a positive or a negative result. But if we compare MPO from SBB, SBB will give a more positive result compared to MPO. M6 is for acute erythroleukemia, but this is both erythrocytic and myelocytic in origin, so it can also give either a positive or a negative result. And the rest of the positives would be the other myeloid cells, which is neutrophil and monocyte with a positive reaction. Next, we have the esterases. NASDA stands for the specific esterase, while the ANA stands for non-specific esterase. Specific esterases are for the identification of granulocytes, while the non-specific esterases are for the identification of monocytes. So therefore, all cells with granulocytes would be positive for specific esterases, while the monocytes would have a positive reaction for those with monocytic cells. So that would be M4, which is myelomonocytic, M5 monocytic, and of course the monocytes. M7 is megakaryocytic, and as mentioned in the discussion, megakaryocytes may be positive for non-specific esterase. Let's also mention that the combined esterase stain or the dual esterase test is used for the identification of M4, and this will give a positive reaction for both the specific and the non-specific esterases. Next, we have the periodic acid shift, which is mainly used for the identification of M6 or the de Guglielmo's syndrome. But since most of the cells would be positive for glycogen and therefore positive for PAS, except for the myeloblasts present in M1. Other notable mention for PAS would be the pattern present in the different kinds of cells. So M3 will have a blush pattern. M6 and M7 would either have a diffuse or a granular pattern. And ALL will give a polar pattern of positivity. A deviation of the PAS is the TRAP staining, which stands for tartrate-resistant acid phosphatase, which is used for the identification of hairy cell leukemia. And lastly, we have TDT, which stands for terminal deoxynucleotidyl transferase, which is an enzyme marker for primitive lymphoid cells, therefore a positive for ALL. And that is it for this video about cytochemical stains. Hope you learned a lot. Thank you very much for watching.